John is a 32-year-old man who enjoys playing basketball with his friends every weekend. Last week, he started feeling tired and weak, and he had some chest pain during his game. He thought that it was just some amount of muscle soreness and he took rest for a few days. However, his symptoms persisted and he developed fever along with shortness of breath. So what is myocarditis? Myocarditis is basically inflammatory disease of cardiac muscle, which is caused by a variety of infectious and non-infectious conditions. It can be subdivided into acute, subacute, or chronic disorder. It can actually present with either focal or diffuse involvement of the myocardium. Then you have many inherited cardiomyopathies, such as Fabry's disease and arrhythmogenic right ventricular cardiomyopathy, which may present with features of acute or chronic myocarditis. So what causes it? There's a huge list actually. I just put it forward. I borrowed it from Up to Date, and actually there's a long list of infectious causes as well as the non-infectious causes, hypersensitivity reactions, as well as certain systemic disorders such as celiac disease, most prominently, and certain other diseases such as sarcoidosis and thyrotoxicosis, to name a few. So the problem statement when it comes to talking about myocarditis is, what exactly is the problem in terms of knowing it more? Well, it has got a very ill-defined frequency, to state the obvious, and it has got a very extremely variable clinical presentation. There's no absolutely, gold standard test in this. There's no sensitive or non-specific, non-invasive diagnostic test in this. So what are the clinical manifestations when it comes to, nailing a patient of myocarditis? It would be excessive fatigue or exercise intolerance. You have chest pain, unexplained sinus tachycardia, S3, S4 gallops, abnormal ECG, abnormal echocardiograms, new cardiomegaly on chest radiograph, atrial or ventricular arrhythmia. When I talk about abnormal echocardiograms, I talk about LV dysfunctions, I talk about regional wall motion abnormalities, which can all come in a patient of myocarditis. When you've got partial or complete heart block or a new onset bundle branch block, then you've got a new onset of worsening heart failure. Then you have acute pericarditis, cardiogenic shock, sudden cardiac death, respiratory distress or tachypnea, and hepatomegaly, just to name a few. Now, when we talk about a clinicopathological classification, basically this would utilize both the histologic and clinical features, which may actually aid your diagnosis, management, and prognostication in those patients of heart failure who have heart failure owing to myocarditis. You have acute forms such as fulminant myocarditis and acute myocarditis, and chronic active myocarditis and chronic persistent myocarditis, which can actually, sort of intersect with the different clinical profile presentations that we see in patients. So going into profiles of myocarditis, you can get acute coronary syndrome like chest pain in absence of angiographically discernible disease with STT changes. You can get drop eye elevations along with RV and LV dysfunctions on echoes. You can have a patient who has got new onset or a worsening heart failure over 2 weeks to 3 months, along with the progressive dyspnea, fatigue, and chest discomfort. And if you do an echo at this point in time, they have got a left ventricular or right ventricular dysfunction along with non-specific ECG changes. And these are usually preceded by a respiratory infection, GI infection, or for that matter, in a postpartum state. When you've got pleuritic chest pain or pericardial effusion, then you can develop hemodynamic. You can have a patient who develops hemodynamically significant arrhythmias, or these patients can land up to you with cardiogenic shock. So when we come to subacute or chronic myocarditis, there are two terms that we should be aware of. One is a chronic active myocarditis, which is characterized by frequent clinical and histologic relapses. You can get new onset ventricular systolic dysfunction along with chronic inflammatory changes. And if you do an endomyocardial biopsy in these patients, you can get mild to moderate fibrosis. Chronic persistent myocarditis, which is described as presenting with a less distinct onset of illness, but there's a definitive persistent histologic infiltrate. You get foci of myocyte necrosis, absence of ventricular dysfunction, despite the fact that these patients may keep on having persistent chest pain or palpitations. Other signs and symptoms, you can get myalgias. You can get patients who give history of frequent URTIs. These patients would be usually between the age of 20 to 50 years. They can give you history of having recent onset infections, especially GI or upper respiratory tract infections, and tachycardia, which is out of proportion to fever, along with a history of receiving a recent vaccine. What about cardiac manifestations? You can get fatigue or decreased exercise capacity, which can lead to heart failure with decreased ejection fraction and dilated cardiomyopathy. As told before, signs of left ventricular or right ventricular failure. You can have chest pain with or without pericarditis, along with elevated troponins, such as it can be both troponin T as well as I. You can see these patients having sudden cardiac death or arrhythmias. That is what they can present with. What about physical examination findings? Physical examination, by and large, is non-specific, but you may get to see some signs of volume overload. You can get to see some signs of or some evidence of cardiac dysfunction. You can get MR or TR murmurs of new onset, which can be functional. You can get a pericardial friction rub or effusion. Now, how do you work up a case basically? If you suspect a myocarditis, what do you exactly see here? You can look for elevated CRP levels, elevated ESR levels, along with peripheral eosinophilia. You can develop, you can have patients with elevated brain natriuretic peptide or anti-pro BNP levels. You can have patients with elevated troponin levels. These patients can have new onset arrhythmias along with STT changes on ECGs. When we take it further in terms of failure manifestation, these patients can also have pleural effusions as well as pulmonary congestion on chest X-ray. What about ECG? Now, ECG can be absolutely normal. It can be non-specific. You can get a spectrum from STT changes to complex ventricular arrhythmias. Occasionally, these patients also may have atrial tachycardia and atrial fibrillation. Usually, high-grade AV block is uncommon when it comes to lymphocytic myocarditis, but it is common if your patient is having Lyme disease or cardiac sarcoidosis, or for that matter, idiopathic giant cell myocarditis. You can get presence of Q waves or left bundle branch block, which is actually associated with higher mortality, and these patients can have a new onset pericarditis. Chest X-ray wise, heart size varies from normal to enlarged with or without pulmonary vascular congestion. You may get pleural effusions to go with it. You have biventricular cardiomegaly at times, which is actually associated with absence of pulmonary congestion, such as in those with right ventricular and or moderate or severe tricuspid regurgitation. There's a very limited sensitivity for identification of cardiomegaly or for diagnosis of heart failure. Endomyocardial biopsy diagnostic criteria. There is a criteria which has been put forward, DULLUS, and the need for doing a biopsy should be based upon the likelihood that actually your results will change the management. So that is, if you have intractable failure and you're not reaching anywhere, that is the point in time you decided, okay, I should try this. You should look at the time course of these patients. You should look at the severity of manifestations in these patients along with the characteristics. And if you have a patient who has got unexplained fulminant hepatic failure, then definitely you can go in for an endomyocardial biopsy. What about outcome predictors? If your patient has got a complicated myocarditis wherein initial ejection fraction of the LV would be less than 50%, along with sustained ventricular arrhythmias or low cardiac output syndrome, which actually requires mechanical circulatory support or inotropes, that's a bad prognostic indicator. Then cardiac specific autoantibodies, if you find them, they appear to be associated with the worst prognosis, especially in patients with chronic myocarditis, but a better prognosis in those patients who have an acute myocarditis. Now, higher titers of IgG are also associated with better left ventricular function in the myocarditis treatment trial. What about etiological factors in terms of having effects on prognosis? Severity of left ventricular or biventricular dysfunction actually correlates directly with the bad prognosis. Syncope or a bundle branch block or an ejection fraction of less than 40% is a portender of bad prognosis. Development of secondary pulmonary hypertension with rise in mean pulmonary artery pressures, bad prognosis. New onset severe heart failure, which requires parenteral inotropic or mechanical circulatory support, again, bad prognosis. Then there's a subtype, which is lymphocytic fulminant myocarditis. That actually is associated with a better prognosis. And sometimes, if the viral genome remains persistent in the myocardium, then it can give rise to a bad prognosis in the future.